You know that feeling, right? Staring at a pile of revision notes, maybe the ones you've made yourself, and thinking, okay, I wrote it down, but do I really get it? Can I pull out the important stuff? It's tough, especially with complex medical topics.
Absolutely. It's one thing to gather information, quite another to distill it,
Mm.
especially when you need it fast, like for the MSRA or just, clinically.
Yeah.
Getting a solid grasp is key.
Well, that's exactly what we're doing today. You've shared your notes on Parkinsonism, and our mission essentially is to dive into them together. We'll unpack the really crucial bits, focusing just on making it clear and memorable for you.
Yeah, we're looking forward to it. Think of it as highlighting the main pathways through your notes, pointing out the absolute must-know landmarks.
Okay, let's dive straight in. Your notes start with the definition, which seems like the right place. Why is getting that definition absolutely nailed down so important for Parkinsonism?
It really is the foundation, because if you misunderstand the basic term, everything else gets muddled. So your notes correctly define Parkinsonism not as a single disease, but crucially as a group of neurologic disorders.
Okay, right there, that's a huge point. It's a category, not just one condition.
Exactly. And the thing that ties this group together, according to the material, is the presence of motor symptoms that look a lot like those in classic Parkinson's disease.
So the way it looks, the symptoms are similar to PD, but the why behind it could be different. And those classic motor symptoms listed in your notes.
Yep, the absolute essentials. The notes list the four big ones. Tremors, often that resting tremor you see. Bradykinesia, which just means slowness of movement. Rigidity, that stiffness or increased muscle tone. And postural instability, which affects balance, usually a bit later on.
TRBP, tremor, rigidity, bradykinesia, postural instability. Those four, a core. You got to remember those. Maybe think TRBP or like a TRP that slows movement. Just swap the A for B and add the R, whatever works for you.
Finding that hook definitely helps. And your notes make another really vital distinction here. Parkinsonism is the umbrella term, the group, whereas idiopathic Parkinson's disease, or PD, is just one specific diagnosis that falls under that umbrella.
That feels like a super high yield point for revision. Parkinsonism is the broad category. Idiopathic PD is just one type within it. For you, the listener, why is really getting this distinction right so critical?
Well, because if you mix them up, you might make wrong assumptions about causes, about prognosis, even about how someone might respond to treatment. Seeing Parkinsonism tells you about the symptoms, but it immediately flags that you need to dig deeper to find the specific cause.
Right, finding that specific cause. Which leads us perfectly into the next section in your notes. Etiology. The why. If it's a group showing similar symptoms, what are all the different things that can actually cause Parkinsonism? Your notes have quite a list.
They really do. They highlight just how varied the origins can be. The most common causes listed are, first, idiopathic Parkinson's disease itself. That's the most frequent one. Then you've got drug-induced Parkinsonism, vascular Parkinsonism, and then this group called atypical Parkinsonian syndromes.
And those atypical syndromes are specific conditions themselves, right? The notes name a few key ones.
Yes, specifically mentioning multiple system atrophy, or MSA, progressive supranuclear palsy, PSP, and corticobasal degeneration, CBD. These are really important to know because they often behave quite differently from typical PD.
Okay. And there's also a list of rarer causes included.
Yeah, bringing in things like Wilson's disease, neurodegeneration with brain iron accumulation that's a mouthful, and post-traumatic Parkinsonism.
Plus even more specific examples like after encephalitis or dementia pugilistica, the one linked to chronic head trauma like in boxing.
And they also mention toxins like carbon monoxide poisoning, or MPTP, that specific neurotoxin known to induce Parkinsonism.
Wow. That is quite a range of causes, from a degenerative process we don't fully understand in idiopathic PD to things like medications, strokes, toxins, even head injuries.
It really drives home that just because the symptoms look similar doesn't mean the underlying cause is the same.
Huh.
And that drug-induced category is so important because potentially it's reversible.
Right. And your notes point out some specific drugs that are common culprits for drug-induced Parkinsonism.
They do. They flag antipsychotics and metoclopramide as ones to watch out for. And really importantly, they add that specific detail that Domperidone doesn't usually cause these extrapyramidal side effects. That's a high-yield difference to remember.
Okay, so we've got this huge variety of potential causes, all leading back to those TRBP symptoms. What's sort of fascinating here is how do such different things manage to disrupt the brain in a way that ends up looking so similar?
It generally comes down to the brain pathways they affect. Many of these different causes ultimately impact the dopamine system, particularly in the basal ganglia, which are crucial for movement control. They just get to that point of disruption through different routes.
Which logically brings us to risk factors. Given all these causes, who's more likely to develop one of these conditions?
Well, the material points out, quite logically, that the risk factors aren't the same across the board. They vary depending on the specific underlying cause.
Makes sense. But there are some major ones that seem to cut across several types.
Definitely. We just talked about drugs, antipsychotics, some antiemetics like metoclopramide. Even certain calcium channel blockers are listed here again as things that increase risk if someone is taking them.
And what about the single biggest, most consistent risk factor mentioned?
Age. It's highlighted as a really significant risk factor for most forms of Parkinsonism. The chance of developing it definitely increases with age.
So getting older is a strong predictor for many types. Anything else major?
Genetics comes up. Your notes mention that some genetic factors do contribute, and they specifically flag this as being especially relevant for those atypical Parkinsonian syndromes. While there's a genetic component in idiopathic PD too, it's often more complex. In some atypical forms, the genetic link can be clearer.
Okay, thinking about this for revision. Knowing these risk factors helps focus your clinical suspicion, right? If you see an older patient developing movement problems, Parkinsonism is higher on the list. Or if a patient starts an antipsychotic and then develops a tremor, these factors should ring alarm bells.
Exactly. They're important clues that help you consider the right possibilities.
All right, we have the causes, we know who's more at risk. Now let's get into the biology. Pathophysiology. How do these different causes actually mess with the brain to create those motor symptoms?
Well, just like the causes, the underlying biology, the pathophysiology, it also varies quite a lot depending on the specific type of Parkinsonism. It's not one single mechanism.
But the notes do focus on the mechanism for the most common type, idiopathic PD.
Yes. For idiopathic PD, the absolute core issue is the progressive damage and death of neurons that make dopamine. This happens very specifically in a part of the brain called the substantia nigra. When you lose these dopamine cells, you get less dopamine, and it's that shortage that causes the classic TRBP motor symptoms.
So in typical PD, it's a direct hit on the dopamine supply in a key movement control center. What about the other types mentioned briefly?
The notes suggest different processes. For vascular Parkinsonism, it's thought to be damage from small strokes or just poor blood flow affecting those movement pathways. For the atypical syndromes, it often involves the buildup of different abnormal proteins in different brain areas compared to idiopathic PD, leading to more widespread issues.
And connecting this to the big picture, understanding the how, the pathophysiology directly links to treatment, doesn't it? If the main problem is lack of dopamine.
Then treatments that replace or mimic dopamine make sense, which is why levodopa works so well for many with idiopathic PD. The notes really stress that the specific pathophysiology shapes not just the symptoms, but also how well treatments work. Someone with vascular Parkinsonism, for instance, might not get much benefit from dopamine meds.
That leads us perfectly into the next challenge, differential diagnosis. You've got similar symptoms, multiple causes. How do doctors actually figure out which specific type of Parkinsonism someone has? This seems like the real detective work.
Absolutely. The main goal here, as your notes say, is to tell these underlying causes apart. Just saying it's Parkinsonism isn't enough. You need to nail down the specific diagnosis for proper management and prognosis.
And the main things they're trying to separate are those big categories we discussed.
Exactly. Is it idiopathic PD? Is it drug-induced? Is it vascular? Or is it one of the atypical syndromes?
So how do they actually do that in practice? What tools do they use?
Well, neurologists rely hugely on a really detailed clinical history and a thorough neurological exam, looking for very specific clues. Then, they often use formal diagnostic criteria or scoring systems. Your notes mention two key ones: the UK Parkinson's Disease Society Brain Bank criteria and the Movement Disorder Society criteria. These systems look at things like how the symptoms started, if one side was affected first, how well the person responds to levodopa treatment, and importantly, the presence or absence of those atypical features we'll talk more about.
Okay. So it's structured detective work using these established criteria. For revision, you could think through scenarios, right? Like, patient has sudden onset Parkinsonism right after starting a new drug, points strongly to drug-induced. Or patient has the motor symptoms, but also really early bad balance problems and dizziness on standing that might steer you away from typical PD and towards an atypical one like MSA.
Precisely. Spotting those red flag symptoms or signs that don't fit the classic picture of early idiopathic PD is absolutely vital in this differential process.
Okay, let's shift gears slightly. Epidemiology, numbers. How common actually is Parkinsonism? And is there a big difference between the subtypes?
Your notes are clear that the prevalence really varies by subtype.
What about the most common one? Idiopathic PD.
Idiopathic Parkinson's disease is, by a significant margin, the most common form. The notes give that UK statistic. Around 1 in 350 adults over the age of 40 are affected. So yeah, it's a condition you're definitely going to encounter.
And the other types?
Drug-induced and vascular Parkinsonism are also fairly common, though maybe not quite as prevalent individually as idiopathic PD. The atypical syndromes, MSA, PSP, CBD, they're described as being rarer, but still crucial to know about because their course is so different.
And the overall trend across all types reflects that risk factor we talked about.
Yes, absolutely. The overall prevalence of Parkinsonism, when you group all types together, clearly increases with age.
So thinking about this, why is knowing these rough frequencies helpful when you see a patient?
It helps set your baseline suspicion. If you see a 30-year-old with a tremor, simple essential tremor is far more likely than Parkinsonism. But if you see an 80-year-old developing bradykinesia and rigidity, idiopathic PD jumps way up the list because it's common in that age group. It helps you weigh the probabilities.
Right. Let's get more descriptive now. Clinical presentation. We know the core TRBP symptoms, but what else might you actually see? What does Parkinsonism look like beyond just those four things?
Okay, so we definitely start by reinforcing those core motor features again. Resting tremor, bradykinesia, rigidity, and postural instability. You need those for the diagnosis of Parkinsonism.
But your notes list other features too, things that really paint a clearer picture.
Yes, these additional features are really characteristic. Things like a shuffling gait, where the person takes these small, hesitant steps, reduced arm swing when they walk, masked faces that sort of lack a facial expression, looking a bit flat, and micrographia, their handwriting gets really small and cramped.
Those are great visual clues. For memory, you could picture someone walking with tiny steps, arms barely moving, face quite still, and then imagine them signing their name really tiny.
Yeah, visualizing it definitely helps lock it in. And then, the notes highlight something really critical for telling the types apart. Some forms of Parkinsonism, especially the atypical ones, often have additional features quite early on that you wouldn't typically see in early idiopathic PD.
These are those red flags, again, helping differentiate.
Exactly. These can include things like early and severe autonomic dysfunction, meaning problems with blood pressure control, causing dizziness, severe constipation, urinary issues, erectile dysfunction appearing early. Also, cerebellar signs coordination problems, clumsiness, or an unsteady gait that looks more like a cerebellar issue. And significantly, prominent cognitive impairment or dementia occurring early in the disease around the same time as the motor symptoms.
Why are these early prominent extra features so significant?
Because they are not typical of early idiopathic PD. If you see someone with clear Parkinsonian motor signs, but also major issues with blood pressure control or thinking, or clear cerebellar type incoordination right from the start, you should strongly suspect it might be MSA, PSP, or CBD, not just straightforward PD. They're key differentiating signs.
Okay, so you've gathered the history, done the exam, seen these features, and you have your list of possible diagnoses. What tests might actually be done to help confirm things and figure out the cause? Investigations.
Right. The main goal of investigations here, according to your notes, isn't usually to prove Parkinsonism exists. That's mostly clinical. It's more about identifying the underlying cause and helping separate those subtypes we've been talking about.
What are the main types of tests mentioned?
Neuroimaging is pretty standard, usually an MRI or sometimes a CT scan of the brain. The main reason is often to rule out other things that could cause similar symptoms, like a stroke, a brain tumor, or normal pressure hydrocephalus. Sometimes the scan might show patterns, like evidence of small strokes suggesting vascular Parkinsonism, or specific patterns of brain shrinkage seen in some atypical syndromes.
And there's that more specialized scan you mentioned earlier.
Yes, the dopamine transporter scan, or DAT scan. It's not used everywhere, but it can be helpful. It essentially measures how many dopamine transporters are present in certain brain areas, which reflects the health of those dopamine-producing neurons. If the signal is reduced, it supports a diagnosis where dopamine neurons are lost, like idiopathic PD or some atypical syndromes. If the DAT scan is normal, it might suggest something else, like essential tremor or maybe drug-induced Parkinsonism, where the neurons themselves aren't necessarily degenerating initially.
Okay. What else is on the investigation list?
Blood tests are mentioned, mainly to screen for reversible or treatable causes, like metabolic issues or Wilson's disease.
Hmm.
Genetic testing might be considered in specific situations, especially if an inherited form or an atypical syndrome is suspected based on family history or clinical features.
And a lumbar puncture. Is that common?
Less common for typical PD, but yes, lumbar puncture to analyze the cerebrospinal fluid, CSF, can sometimes be helpful, particularly when trying to diagnose certain atypical Parkinsonian syndromes. They might look for specific protein levels or other markers in the CSF. But it's really important, as the notes say, that these investigations are tailored. You don't just order everything for everyone. It depends heavily on the clinical picture and what specific cause you're suspecting.
Right, so the tests add pieces to the puzzle you started building with the history and exam. Okay, let's say you've reached a specific diagnosis, or at least strongly suspect a particular type. How do you manage it? What's the approach, focusing on what your notes say, maybe with a UK context?
The core ideas outlined are: 1, address the underlying cause if you possibly can, like stopping a causative drug. 2, control the symptoms to improve the person's function. And 3, maintain their quality of life as much as possible.
And the main tools for treatment listed are?
Medications are definitely central for symptom control, particularly levodopa and dopamine agonists. These directly target the dopamine system and tend to be most effective for the motor symptoms in conditions where dopamine deficiency is the main driver, like idiopathic PD.
But it's clearly not just about pills, right?
Oh, absolutely not. Therapy is incredibly important. Physical therapy is key for mobility, balance, and preventing falls. Occupational therapy helps people adapt to challenges in daily activities, maybe suggesting aids or home modifications. These non-drug approaches are vital for independence.
And other supportive care?
Yes, things like speech therapy if there are voice or swallowing problems, which can happen. And psychological support is often needed too, because mood issues like depression and anxiety are unfortunately quite common alongside Parkinsonism.
And the notes stress that this isn't a one-off treatment plan.
No, definitely not. Parkinsonism, particularly the regressive forms, changes over time. So management needs regular review, monitoring how things are going, and adjusting treatments as symptoms evolve.
And who typically delivers this complex care?
It really needs that multidisciplinary team approach. You'll have neurologists, specialist nurses, physiotherapists, occupational therapists, speech therapists, sometimes dietitians or psychologists, all working together.
How does the management strategy change depending on the type of Parkinsonism?
Yeah, this links straight back to the pathophysiology. Levodopa and dopamine agonists often work really well in idiopathic PD. They can also help in drug-induced Parkinsonism, especially once the drug is stopped. But they're often much less effective, or sometimes not effective at all, in vascular Parkinsonism or the atypical syndromes, because the main problem there isn't just a lack of dopamine from the substantia nigra. So for those types, management might lean even more heavily on therapies, managing specific non-motor symptoms like blood pressure drops and supportive care.
That makes total sense. You tailor the treatment to the underlying biology or the most pressing symptoms, which really differs between the subtypes. Okay, nearly there. Prognosis. What's the likely outlook for someone with Parkinsonism, and how much does it depend on the specific type they have?
Your notes are very clear on this. Prognosis varies significantly depending on the underlying cause. Yet another reason why getting that specific diagnosis right is so important.
So for idiopathic PD, the most common type.
It's described as a chronic, progressive condition. But, and this is key, the speed of progression varies hugely from person to person. It's not a uniform decline. The notes emphasize that with good, comprehensive management, people can often maintain good function and quality of life for many, many years. It's definitely manageable, even though it's not currently curable.
How does that compare to the atypical syndromes?
Generally, the atypical syndromes like MSA and PSP tend to progress more rapidly and are associated with a shorter lifespan and more disability overall compared to typical idiopathic PD. So a poorer prognosis, unfortunately.
But there's a potential upside for some types.
Yes, the potentially reversible forms. If it's drug-induced Parkinsonism, stopping the offending drug can lead to significant improvement, sometimes even complete resolution of symptoms. Similarly, if there's another treatable underlying cause, like Wilson's disease, addressing that can improve the Parkinsonian features. What's really striking here is how knowing the specific type of Parkinsonism directly informs the conversation about the future. It sets expectations for the patient and the whole clinical team.
Okay, last section from your notes, complications. As Parkinsonism progresses, what other problems might arise?
The notes list quite a few potential challenges. There are motor complications, often linked to long-term levodopa treatment in PD, like motor fluctuations, those on-off periods where symptoms return before the next dose, and dyskinesias, which are those extra involuntary wriggly or dance-like movements.
And then there are the non-motor complications listed, which sound pretty significant too.
They really can be. Sometimes they become even more troublesome than the movement issues. These include things like cognitive impairment, potentially progressing to dementia, mood disorders like depression or anxiety, significant sleep problems, worsening autonomic dysfunction affecting blood pressure, bowels, bladder, and a really major one falls due to the postural instability and balance problems.
So the broader challenge, as the notes mention, is that progression often leads to increasing difficulties with just getting around, staying balanced, and managing everyday tasks.
Exactly. It impacts daily life significantly. But the notes do end on a positive point, reinforcing that good, comprehensive, multidisciplinary care is aimed squarely at minimizing these complications, managing symptoms, and ultimately improving outcomes and quality of life as much as possible.
Wow. Okay, we have really unpacked your notes on Parkinsonism today. A proper deep dive. We've gone from the definition, remembering it's a group of disorders with those core TRBP motor symptoms, through all the varied causes, the risk factors like age and drugs, the different ways the brain can be affected, how doctors tell the types apart using clues and criteria, how common it is, the full clinical picture, including those extra revealing features, the management mix of meds and therapy, the variable prognosis depending on the type, and finally, the potential complications.
Yeah, it really underscores how thinking of Parkinsonism as this diverse group, not just equating it with PD, is absolutely fundamental. It shapes how you understand everything, from symptoms to treatment response to the long-term outlook.
So here's a final thought for you to mull over as you review your notes. Now that we've laid it out as this collection of conditions with different origins and paths, how does that sharpen your thinking? When you encounter a patient or an exam question, are you more actively looking for those subtle clues, the atypical features, the drug history, the speed of onset that help you pinpoint which specific type of Parkinsonism you might be dealing with?
Hopefully, breaking it down like this, following the structure of your own notes, has made the whole topic feel a bit more manageable and higher yield for your revision.
Thanks so much for letting us dive into your notes with you on this really important topic. Keep going back over this stuff. Maybe listen again to cement those key distinctions and use it to really strengthen your understanding.
And look, if you're after more top-notch resources specifically built for this kind of high-yield medical revision, the sort of focused learning we've talked about, definitely check out MSRA.com.
Yeah, they've got some great tools to help you really get to grips with these complex areas. And if you want to put your knowledge to the test with free practice questions designed around this essential content, head over to freemesrastory.com.
Both really solid platforms to support you as you prepare.
Thanks again for joining us for this deep dive. Keep learning, keep questioning, and we'll catch you next time.